Hi, is my screen visible?
Yes, sir.
Yeah, we'll begin with asking. So the first question is, we had 3.2 kg baby born to primary gravida at around 39 weeks of gestation by forceps assisted vaginal delivery. Baby cried after tactile stimulation. The Apgar scores are 5 and 7. A resident doctor identified a swelling in the head as shown in the figure around 4 hours of life, and it is painful. And the swelling doesn't cross the suture lines. So this is swelling. So and there is a local movement. I'm not able to open the chart. Okay, we'll move on. So as you can see that we have three kind of swellings in the head. One is the caput succedaneum, where you have a fluid in the or below the skin, which crosses the suture line. And we have in the second figure, we have a subgaleal hemorrhage, where you have a bleed in the subgaleal space above the periosteum, and it can extend throughout the subgaleal space, extending from your occipital ridges to the posterior occipital prominence. So ocular ridges to the post-occipital prominence, and it will be felt as a soft fluid-like things. And we have a cephalohematoma, which is a painful swelling that is present below the periosteum. The green color is the periosteal lining, and below that there is a fluid connection, and it is below the periosteum. It usually doesn't cross the suture line. The cephalohematoma can be associated with some amount of fractures also. So it's a cephalohematoma. The second question is, where is it present? It is present in subperiosteal space. And what do you want to do? You will reassure and monitor for the jaundice, because the amount of the based upon the amount of the blood that is accumulated in the extravascular space, the jaundice levels can be shoot up. Usually the hemolysis in the extravascular space starts after 48 to 72 hours after the collection. So may not have a jaundice on the day one of life. They develop jaundice after 48 to 72 hours of life. So you need to reassure and monitor for the jaundice in the baby. So this baby has been didn't at birth, and the baby is kept in this machine. So what is the procedure being done? What is the mechanism of action? And what are the common side effects? Actually, I'm not able to open the chat. If someone want to, they can speak.
No, sir, they can't.
They can't. So someone can read the chat, because I'm not able to open the chat. In this, it's not allowing. Okay, then we'll move. So this is a therapeutic hypothermia, total body cooling, where the baby is therapeutic hypothermia, where the baby is being cooled to the 33.5 degrees centigrade. So the mechanism of action is, so it decreases the basic metabolic rate, so decrease energy consumption both in the body and the brain. And it inhibits the accumulation of your glutamate, which is the excitatory neurotransmitter. Whenever your glutamate get accumulated, it will increase the more amount of the action at the glutamate receptors in the nerves. It can lead to more amount of calcium entry, generation of reactive oxygen and nitric species. It can actually causes caspase activation and causes secondary damage. It also inhibits the inflammation. Usually will start within first 6 hours, but because in the first 6 hours, usually when the baby had a perinatal asphyxia, because of the impairment of the oxidation, so I know the transporters get affected. So in the first 6 hours of life, majority of the injury is caused by because of the accumulation of sodium. The swelling of the cells will happen and necrosis will happen. After around 4 to 6 hours of life, when the blood circulation re-established, there more amount of the blood is going to the brain, reperfusion injury happens, then there will be more amount of your reactoxin species generation will happen, more amount of glutamate accumulation will happen, which increase more amount of the calcium entry, activation of your caspases, mitochondrial damages, then that lead to more amount of necrosis. So that is why we need to treat these babies within the first 6 hours. But the problem nowadays has been done in multiple trials is we don't know when the asphyxia has happened, whether it happened intrapartum or before, just before the delivery, or it has happened at the time of delivery. So this 6 hours is kept as an arbitrary. So the debate is whether this 6 hours has happened before the birth or during the birth, after the birth. But traditionally, we'll cool the babies within the first 6 hours of life. There are certain studies that has been done after 6 hours of life also, where they have found that the probability of neurodevelopment disability is decreased by 75%, but there are not much studies. And there are the most common side effects associated with the cooling are sinus bradycardia, which doesn't affect the cardiac output, and there will be thrombocytopenia. So that is why the therapeutic hypothermia, we need to monitor the platelet. Along with the plate thrombocytopenia, the baby also might have this platelet dysfunction. So we need to maintain the platelet count beyond 1 lakh. There can also happens other side effects, like you can also have this mild elevation of pulmonary pressures, and also there can be subcutaneous fat necrosis. So these are all the things that need to be monitored in the baby providing therapeutic hypothermia. And there will be fluctuations in the blood pressure, but it itself doesn't cause the hypotension. But if any baby who had an hypotension, the cooling can increase the chance of having the more amount of hypotension, not because of itself, but because of our inability to monitor the perfusion in these babies. So in these babies, we usually establish the arterial line, and also we manage the perfusion index, which we find the baseline, and over the time we'll see how much it is getting fall. Because once we have started the cooling, we don't know what is the, we can't assess the peripheral pulses, CRT and all the things. So next is we have a 2.7 kg baby born by emergency CS in view of fetal bradycardia. And the baby didn't cry at birth. Baby received resuscitation till chest compressions, and subsequently baby has been revived and has been admitted in ICU. The baby had a tachycardia, which is around 180, had a delayed CRT around more than 4 seconds, and the baby had hypotension with poor peripheral pulses. What is the cause of the shock? So in these babies who are having the resuscitation, perinatal asphyxia, where the baby had an acidosis, required chest compression, your myocardial contraction will be impaired. So these babies usually have a cardiogenic kind of shock. So the myocardial contractility will be very poor. So how do you assess the cardiac contractility? So you assess the cardiac contractility based upon the echo parameters. So one, the most common thing that we'll do without training also, we'll put a, we'll see the probe in the 4-chamber view, where you can have this cardiac contractility is not good. That's called eyeballing. And if you want a more an objective rather than subjective evidence, we need to do the echo parameters. So one is, what is this? What are the view that we are using here? So this is a parasternal long axis view, where you have been put an M mode line across your left ventricle. So this is the fractional shortening view. The fractional shortening is how much the left ventricle is contracting in that beat. So where you can see this fractional shortening, we can have this large thing is your diastole will be dilated, and during the systole, the chamber will be contracted. So we'll calculate, we'll measure this thing, and we'll measure the left ventricular ejection, left ventricular during the diastole, and left ventricular size during the systole. And we have the formula of left LVEDT minus LVESD divided by LVED. So maximum minus minimum by maximum. So normally the fraction shortening in the newborn babies is 25 to 44%. So anything less than 25% is called as impairment of the myocardial contractility. There you can treat the baby for increasing the contractility. So can anyone identify the instrument that has been shown in the figure? Oh, I can see the chart, I think. Yeah, it's rightly said it is a flux meter. So it's a flux meter. It's actually is needed for the measuring the irradiance of the photometry unit. And the measurement is a microwatt per centimeter square per nanometer. See, ideally, all the NSUs nowadays are using the LED phototherapy lights. So over the period of time, certain hours has been detected by the equipment, they will lose the irradiance power. So we need to measure this irradiance monthly or every fortnightly, and need to assess the irradiance. So at least it should generate around 20 to 30 microwatt per centimeter per nanometer, because below that, if you provide the intensity of the phototherapy is not adequate, and your jaundice might not get improved. So can someone identify the condition? Now I'm able to see the chart, so you can type in the chart also. Yeah, it's a tongue tie. So what are the different tools for evaluation? Okay. So this is a tongue tie. We have a TABI scores, Bristol tongue assessment score, and we have the Hasselbalch assessment tool for the lingual frenulum function, where routinely we do the TABI score based upon how much the tongue is attached, how much able the baby is elevate to the tongue, what is the shape of the tongue, and how much the baby is able to protrude the tongue. So based on that, we have the scores. So the highest scores are reassuring, and any score 0 to 3, you usually go for the frenectomy for the baby. And these babies, as they're not able to elevate the tongue properly, not able to propel the tongue, they have the latching and attachment issues are there. So, so this next question is, So what is the most common enzyme in the breast milk which has both the bactericidal effect on the gram-negative bacteria and the bacteriostatic effect on the gram-positive bacteria? Which is the enzyme? Okay. The lysosome is the enzyme that is present in the breast milk which has both bactericidal effect on the gram-negative and the bacteriostatic effect on the gram-positive bacteria. So what is a major whey protein present in the human milk? So we know that the whey protein, yeah, correct. Lactalbumin is the most common major whey protein in the human milk. So the human milk compared to the animal milk has 70% of the whey protein, which is easily digestible, and it acts as the lactalbumin. So it is helpful for the much having a good amount of the lactose, and the digestion will be much easy. The casein protein that is present only in the 20 to 30% in the human milk is the predominant milk present in the bovine milk. Any digestion of the casein protein is very difficult, and the babies usually have difficulties in the digestion of that casein. That is why majority of the babies who have the abdominal pain and the colic kind of the pain in the formula fed babies are because of the casein protein. So which is the most abundant immunoglobulin in the colostrum? Yeah, the secretory IgA is the most common immunoglobulin in the colostrum. The colostrum is the first milk. It's also called as a primary vaccination for the baby, usually in the first 40 to 72 hours, rich in the immunoglobulins, proteins, and also other thing that will be seen in the next thing. So which component of the human milk act as a prebiotic and prevent the attachment of the pathogens to the intestinal epithelium? Yeah, human milk oligosaccharides. The human milk oligosaccharides are the complex carbohydrates which usually consists of the five carbohydrates, which is usually glucose, galactose, enestyl, serine, and also fusic acid and enestyl glutamic acid. So this combination will usually prevent, as it acts as a prebiotic for the growth of the better bacteria, the bifidobacterium infantis, and it also helps in preventing the attachment of your pathogen to the intestinal epithelial cells. It causes certain changes in the receptors. In that way, it can prevent the things. It down regulate the inflammatory process. So they also actually, human milk oligosaccharides can prevent the necrotizing enterocolitis by down regulating the inflammation in the gut, so that they can decrease the chance of NEC. So majority of the milk products has been now been labeled as it have been enriched with the human milk oligosaccharides, but none of them match with the human milk oligosaccharides of the respect to mother. So they might not serve the purpose of the human milk oligosaccharides, which has been supposed to be said by them. So what is the machine use? It's a very common machine. What is the machine use? And what is this is a pulse oximetry. So what is the principle used in this machine? What is the principle of pulse oximetry? Yeah, someone said right. Yes, it's a Beer-Lambert principle. The Beer-Lambert principle is that the amount of the light that is absorbed by the tissues will depend upon the amount of the concentration of that absorbing substance plus the light path. Based upon this, the Bill Lambert said that the pulse oximetry works. But if you go into the depth, there is a spectrophotometry and the plethysmography is the principles where you actually your pulse oximetry is working. Spectrophotometry is the amount of the hemoglobin, the amount of the light that is absorbed based upon your oxy and deoxyhemoglobin, and the plethysmography is the amount of the light that is absorbed depends upon the your arterial pulse. So what is the fractional functional saturation? What is routinely being displayed in your routine pulse oximeter? So is there any difference between the fractional and functional saturation? Okay, we'll discuss that. So what is the OSA? Can anyone say OSA? So OSA is oxygen saturation index. Good. So one is a B Lambert. The next thing is the functional saturation is the ratio that is being proposed by the one is the oxygen that is bound to the hemoglobin. The numerator is common for both them. And the functional is where the denominator is the only that oxygen that can be bound by the hemoglobin and is useful. One is the functional saturation hemoglobin oxidation by hemoglobin oxygenated by deoxyhemoglobin. The fractional saturation is where your hemoglobin that is bound to the oxygen divided by all the kinds of the hemoglobin, both the oxy, deoxy, and also methemoglobin and the coaxhemoglobin. What the thing that we routinely use is functional saturation. We are not using the fractional saturation. The oxygen saturation index is a product of the FiO2 into MAP divided by the preductal SpO2. Normally the OA is it's FiO2 into MAP divided by the with the PaO2. Here if you're not having an arterial line, where we can do the SpO2, your OA is twice of the OSA. So are in around the studies have shown that in the 75 to 99% where you can saturation where you can use OSA in the place of OA when you don't have accessibility to get an arterial sample. So you might have seen this picture nowadays. Recently, last 2 to 3 months, so many cases are there. So what kind of infection, this kind of skin lesions can happen? Yes. So this called as a chikungunya rash. So it's also called a chick rash, where you have the hyperpigmentation seen in the acral area and in the face. So what is the mode of transmission in the neonates? Yeah, the vertical transmission usually happens during the time of the delivery. How do you diagnose this? Okay, it's a congenital chikungunya. The congenital chikungunya is transplant route that happened during the intrapartum period. Nearly 50% of the chance are there when the mother is having the chikungunya around the time of the delivery. And in the first days, we need to RT-PCR. After that, you find that ELISA is useful. After 5 to 7 days, we can identify the antibodies. So we have seen 2 chikungunya cases recently. So one baby was presented to mother with having a fever. The mother was not worked up properly. Later, the baby was discharged. Initially, the baby was discharged as a born with a routine newborn care. Then the baby came around 5 to 6 days of life, presenting with fever, poor feeding, lethargy. But we have not been able to identify the cause in the baby. We have done the routine sepsis screen where the sepsis screen was mildly elevated, CRP was there. Then the baby was started on antibiotics. Initial the investigations were rest of the investigation normal. Baby has a transient improvement. Then again the baby has worsening encephalopathy. Baby was having a shock, thrombocytopenia. When we again work up the mother, then we found that mother had some bone pains, joint pains. Then we done an ELISA in the mother. When we found the chikungunya, then we done the same test in the baby. We found the baby's chikungunya was positive. This baby presents with like a poor feeding lethargy, like any other baby who are in sepsis. Then sometimes in around 40 to 50% of the babies, it can be very fulminating. They can have a multi-organ failure. They can have a bleeds in the bleeds and the case of a infection and the bleeds in the brain. If any baby who had a neurological involvement, the prognosis is definitely poor. The treatment is supportive. We can give this pain relief by paracetamol. We can give the supportive therapy, fluid therapy. We can support the hemodynamics. We can support the ventilation. But once the brain involvement is there, the prognosis is very poor. So we have seen this 27-weeker 800-gram babies on mechanical ventilation at 1 hour of life and received treatment form of surfactant. The pulmonary graphics before and after the surfactant. So what is this graph? Yeah, it's a PV loop. So this is a loop, the loop where you compare the two parameters with each other. In a case of a scalars, where you have a time at the horizontal and you on the vertical, you have a vertical as you the pressure or volume or flow. So when you compare one parameter like a PV pressure and the volume, or you compare the flow and the volume, you can have these loops. So in the PV loops, you can see that this is the where your pressure is starting around 5. This is called because you are not starting with 0 because there's a peep. And here before the surfactant, you have very flat loop. The compliance is low. In order to change, you didn't find any change in the volume with this amount of pressure. But once you give in the surfactant, you can have this increase in the compliance. So you can see that in for this pressure also, you have a for this amount of change in the pressure, you can have a significant amount of volume. So the compliance has improved after the surfactant therapy. So I hope nowadays also we are using all the babies, the loops in order to identify the compliance, air leak, and if you have any beaking here, we can know that the amount of the pressure that are giving might be higher. This is called as beak sign. So the last question is, so we have a term baby was born to the LSCS with history of thick MSL and was non-vigorous at birth. At 6 hours of life, baby is on HFOV, the setting of MAP of 14, FiO2 of 80%, frequency of 10, amplitude of 30. Baby saturation is 92% and the PaO2 is 54 and the PCO2 is 58. So can someone calculate the oxygen index first? So your MAP is 14. Yes. So Can someone calculate A delta word ratio? So that we go to the next slide, we'll go to how to calculate all this. You can roughly tell there's no need for having this all decimals. Okay, we'll discuss. Okay, your formula for OA is map into FiO2 by PaCO2. Your map is 14. Your FiO2 is 80%, and your PaO2 is 54. So you'll get a around 20.7, which has been correctly told. And your A delta O ratio. AO delta ratio need to be calculated in this way. So it is a alveolar oxygen need to be calculated. From that, you need to minus your partial pressure of oxygen. So this PaO2 will get from your blood gas. So for alveolar, we have a formula of P atmospheric P ATM minus pressure of water vapor into FiO2 in fraction minus PaCO2. So this PaCO2 also you are getting in the blood gas. So this 760 is the routine atmospheric pressure at the sea level. This is 760, and the 47 is the water pressure, water vapor pressure. So routinely this will roughly will contain 700. So 700 into FiO2. So the FiO2 in a fraction is 80 by 100. So that will be around your 87 the 560. The 560 divided by 58, that is aroundly your 512. From this 512, you need to minus your PaO2, that is 54, then you will get a 458. So this oxygenation index and the A delta O ratio can assess your how much the baby is having the respiratory distress. In a case of a PPHN, you can even classify the severity of the PPHN based upon the oxygenation index. So routinely we'll do the echo where you get the TRJ. If it is less than 20, it's mild, 20 to 40, it is moderate. So less than 20 is normal, 20 to 40 is moderate, 40 to 60, 20 to 40 is mild, 40 to 60 is moderate, more than 60 of pulmonary arterial pressure is high. Sometimes if you're not having the echo, you can even go by the oxygenation index. In the oxygenation index, anything less than 15 to anything less than 15 is mild, 15 to 25 is moderate, 25 to 40 is severe, and more than 40 is very severe. We know the 20-20-20 rule, so we'll start. I know when with the 20 ppm pressure, when your oxygen index is more than 20, and after that we'll see the PaO2 by FiO2 of improvement of more than 20. This oxygenation index, oxygen saturated index, based upon OSA, you can calculate OA. OA is twice of OSA. So your OA is always higher than OSA. Based upon also, you can calculate the OSA. The problem with OA is if you change the map, it will change. The baby doesn't require high map. If you're providing a very high map in HFOV, then you can change. If you are providing more amount of FiO2, you're not able to titrate the based upon the SpO2, then also you can get the inadvertent high or low oxygenation index. So A delta out ratio where it show that how much of the oxygen is actually getting diffused. So A delta out ratio, anything normal, we can say 5 to 25 is normal. Anything more than 200 is much significant elevated. Anything more than 600 to 800, we definitely go for ECMO. So in this also there is a by A ratio, small a by capital A. So small a by capital A, small a is arterial PaO2, and the capital A is again the alveolar PaO2, the same PaO2. This PA small aO2 by PaO2. Then normally it is 1. Anything less than 0.5 usually suggests of severe respiratory distress in the baby. So in this way we can without echo also we can identify what are the babies who require the I know, and also the babies who we can classify the severity of the PPHN based upon the oxygen index and the A delta ratio. So with this, I conclude my OSCE. So any questions? Okay. If there are no questions, then we'll conclude.
Okay, thank you so much, sir, for such a intensive and informative session. Thank you.
Okay. Thank you, everyone. Thank you for the patient listening. Thank you.
Thank you, sir.